All right, good afternoon, everyone. We want to thank you very much for taking the time to join us today. My name is Jennifer Peoples, and I am the program manager of a program called TCHAT, which stands for Texas Child Health Access Through Telemedicine. We also have Laura Young here, who is the program manager for CPAN, and that stands for Child Psychiatry Access Network. As both programs are sister programs, we decided to do this joint education experience together. So we have participants from both programs attending today. So our presenters today are the wonderful Dr. Kylie Schneider and Elizabeth Hooker, an LPC, and they are going to be discussing managing temper tantrums and explosive anger and helping everyone get a little bit more understanding and broader perspective of not only how to diagnose this and what signs and symptoms to look out for, but also how you can manage this within certain settings. And I will let them take it away.
Okay, good morning, everyone. My name is Elizabeth Hooker. I'm an LPC. My background is working with trauma, especially with those who are survivors of sexual assault. I've worked with children, adolescents, and adults, and I am trained in EMDR.
Hello. My name is Kylie Schneider. I'm currently a child psychology postdoctoral fellow here at UT Health. I am currently working at our new Lake Street clinic too, which is opened up and is going to help us serve a lot of good kiddos. So my background, I do have a training background in trauma, in residential placement, and in neurodevelopmental disorders. And so currently my clinical focus is mostly on parent management training and behavioral management training with a lot of those comorbid things going on. And so hopefully that's what we'll really get to talk about today and help give some insight and hopefully some help, especially as we're going into the new school year. That's a big time for families to be presenting, to your doctor's office, or obviously the kiddos will be coming in and having those grade transitions. And so hopefully some of this will be helpful in giving some guidance and insights for the new year. So, okay. Go ahead and talk about our objectives. Awesome. So today, mostly what we're going to focus on is giving you some, broad brushstrokes understanding, giving you some practical skills to hopefully use, and then being able to reflect some of that application. So we're going to define and compare clinical terminology when it comes to anger and aggression. We're going to describe where some of that comes from and what that means for different diagnostic groups. We'll discuss the methods of intervention in multiple care settings. And then, like I said, we're going to apply it to a specific example. One big thing to know is that we're talking about a lot of diverse populations today, as Jennifer mentioned. So if you have questions about your specific setting, please bring those up. We just kind of hope that those can kind of come up at the end, because we're going to try and hopefully give you a good broad understanding, and then we can get more specifics as those questions and thoughts come up. So, okay, next slide. Okay, and this is just to say that we don't have any financial disclosures or competing disclosures. None of the research that's involved or any of the apps or recommendations that we give, we don't have any financial or personal gain from those. Okay.
So again, today, can you back up one slide, please? Thank you. So we're doing things a little bit differently. We have a very diverse population of both educators and PCPs. So this presentation is going to kind of explain how educators and PCPs can work together to help children's teens and their parents. Next slide, please. So these are different terms that have been used in both the clinic and the classroom setting. And I want you to take a look at these labels. I want you to think about how these can kind of pigeonhole children into these labels. And then how this language can change or meet the needs of the child. And I have had all of these come from just examples of past cases that I've had to work with different kids. These were kind of the labels, or whenever parents were bringing them in, this was the kind of language, buzzwords that were used to describe their child from professionals, from educators and PCPs. Next slide, please. So terminology, we're going to kind of go backwards a little bit and kind of educate you, or this will be a refresher on the different types of anger, because this is a feeling and kind of an emotion. It's a really, really interesting kind of mashup. So we're going to talk about the 3 types of anger. So the first one is passive anger. And this means that, you know, you might not want to admit that you're angry because you don't like the confrontation. This could be something that comes out in things like becoming very silent when you're angry. You might sulk, you might procrastinate, you might pretend everything is fine, which is, I use that a lot. Oh, everything's fine, and it's not. And this comes from a need of wanting to be in control when maybe you don't have the ability to be in control, if that makes sense. There's open aggression, and this is seen in children, teens, and adults. There may be a tendency to lash out in anger or rage. They may become physical or verbally aggressive, and they can oftentimes hurt themselves or others. This is called open aggression. This comes out as fighting, bullying, blackmail, accusing people, shouting, bickering, sarcasm, or criticism. You can have open aggressive comes also from the need of being in control, but instead of that silent part, this is the lashing out type of thing. And sometimes this anger can be taken out on property, people, or even ourselves. So the third type of anger is what we kind of want to strive for. So this is an alternative way of dealing with anger by having self-control and being confident. You're talking and you're listening. You're opening up on how to deal with the situation. This type of anger really helps in relationship and growth. It means to teach the child or the adult to think before they speak. And it's becoming confident on how they say it. They want to be open and flexible to the other side. And this can mean that being patient rather than raising their voice, communicating how their feelings and emotions, and trying to understand what the other is feeling. Note that when children and adolescents learn how to deal with their anger in this type of style, they can be demonstrating that they are mature and they care about the relationship of both them, the relationship they have with themselves and with others. So moving to aggression. This is the behavior or action that can be hostile and destructive or even violent. So for example, can be, but is not limited to physical assault, throwing objects, damaging property, self-harming behavior, verbal threats or insults. Tantrums. This is usually the result of frustration for not being able to have something or avoid something. In children, that frustration may be due to not having the language skills to communicate what is wrong. For example, I'm in pain, or I'm not comfortable with something, or I'm hungry. Tantrums and anger are at a different points of the spectrum. For one is the teaching attention-seeking behavior, and the other is simply trying to get a need taken care of. We have ODD in here, and it's the pattern of angry or irritable mood or arguments. Sorry, this is my therapy cat. The kids really, really like him, and whenever I'm doing presentation, he likes to hop up and make his presence known, so apologies for that. So this is whenever they can have arguments. There's defiant behavior. There's almost vindictive behavior too, and it lasts for about 6 months. Some of the examples would be that they often lose their temper, or they're often touchy or they're easily annoyed, and they're angry and they're resentful for things. They can often be very, very argumental, and they refuse to cooperate with requests from authority figures. For children and adolescents, and then also with adults or rules. They don't like rules. They're going to question those rules, and they're going to almost resent those rules. So they can be annoyed by others. They may blame others for their mistakes or misbehaviors. And the behavior is also disruptive to the children's normal daily function. And this can include relationships and activities with family or with their school. Now, a disruptive behavior is just they are clinically threatened or intimidated others in a violent, or they violate social norms. Next slide, please. Thank you.
Okay, so you know, we talked about some terms for anger and aggression just to kind of understand the difference between experiencing that emotion versus having a behavioral or verbal reaction. And there's a lot of different causes for it. And the first we're going to kind of cover is the more diagnostic causes, because it's okay to be angry, and everyone has moments of angry feelings, or sometimes everybody even has a moment of a tantrum or an aggression. I know we've probably all had moments where we didn't do what we were supposed to. These are common things, particularly in our young kiddos or in our teens. There's a lot of different reasons for things to be going on. And so as we'll talk about today, really understanding a lot about those responses helps us understand, is this maybe something that is, in the moment versus something that is maybe, speaking to a larger, problem area? Because being angry and aggressive doesn't just mean that you have an angry and aggressive kiddo. There can actually be a lot of different reasons for it. So one reason is anxiety. So there's a couple different types of anxiety. Social anxiety is excessive worry or physical symptoms in a social situation where the kiddo perceives that they're going to be judged or embarrassed in some way. Separation anxiety is more specific to caregivers, and so this is where the kiddo has a lot of fear about leaving the home or leaving their caregiver out of fear that something is going to happen to them or their caregiver if they separate. And so sometimes this can mean full refusal to leave or be separated, or sometimes it just means that there's a lot of distress when this happens. Generalized anxiety disorder, I'm sure a lot of us are familiar with. That is just more general kind of excessive worry that the child finds difficult to control, and it can come with physical symptoms as well. And then OCD is an obsessive compulsive disorder, and this is intrusive and repetitive thoughts and or behaviors that the child doesn't want to engage in, but feels like they have to out of fear that something negative might happen. And it impairs their functioning. Kind of all of these things would reach that kind of clinical threshold if it impairs kiddos' functioning, which can, be themselves and what they want to do, but can also be the family functioning. And so what we see with anxiety is your body's alarm system turning on to say, hey, I perceive danger in some way or form. Even if that danger doesn't make sense to most of us or may not be a real danger, that alarm system still goes off. And so as we all know, with our fight, flight, or freeze, fight is one of those responses. So sometimes when that kiddo feels that threat, they can get very angry and very irritable, because it's just part of that alarm system trying to keep them safe. So we can see a lot of anger, a lot of irritability, and at times a lot of aggression when they're feeling anxious. I think we've all probably had an instance where maybe someone's trying to push us towards something we're afraid of, and we start to kind of push and fight back. That could be an example. Depression. So depression is kind of classified in a couple different ways. Obviously, for our kiddos, the main ones are major depressive disorder and then disruptive mood dysregulation disorder. So MDD, a lot of us are, again, probably familiar with. That's an episode of irritable or low mood that's, accompanied with poor appetite, poor sleep, feelings of worthlessness, inappropriate guilt, lack of interest in things, may or may not come with suicidal thoughts or thoughts of death. And that lasts for at least 2 weeks. DMDD is a similar kind of depressive. It's a newer disorder, in the history of the DSM. And so this is extreme emotional outbursts or tantrum outbursts to situations where these outbursts are way out of proportion for what is actually happening. They may persist for a long time, and they happen, about 3 times a week. In between those outbursts, you're going to see that your kiddos are kind of having an irritable and angry mood pretty much all the time. So they're always kind of irritable, and then every so often they'll have these big, huge explosions that are like way out of proportion. And that has to last for at least 12 months to be considered a DMD presentation, as opposed to a different type of mood disorder or behavioral disorder. And typically you're diagnosing this in kiddos, have to be present before age 10, but not before 6 and not after 18. So can apply to, our school age kiddos pretty well. And then you have your adjustment disorders. So adjustment disorders exist to acknowledge that sometimes we just go through stressful things. Life can come with a lot of changes that can throw a lot of stressors on a family, on a child. And so an adjustment disorder acknowledges that, hey, we have some pretty significant behaviors or emotions going on, but we need to be mindful that there's a lot of reasons that this could be happening. And so you can say it's a disturbance in mood, so saying that they're either depressed or anxious or both. They're having a disturbance in conduct, which might be that aggression, or they can present with both. And so when we're looking at depressive and adjustment disorder presentations, on that depression, obviously, like we said, an irritable mood can be part of the depressive presentation. Irritability might escalate when they're feeling pressured, or when they kind of get stuck in their own negative thoughts of, I should be doing better, I should be doing this. And the same goes with MDD. It can also occur because of that, but also, like we said, temper tantrums can just be part of it. And similarly with adjustment disorder, you can see that frustration for the same reasons. Okay, next slide. These are maybe some of the reasons that we think of a little bit more traditionally for aggression and anger are our disruptive and defiant behavior disorders. So like Elizabeth talked about, you can have ODD, oppositional defiant disorder, which, like she was saying, is that argumentative, irritable, or vindictive mood that kind of persists and usually has to last for at least 6 months. What happens there is sometimes what we can see is that impulsivity and poor decision-making can actually get interpreted as aggression. So especially in those behavior tantrums, if I throw something, it's not always because I'm intending to hurt. I might just be having a big emotional expression and I don't have good ability to withhold my impulses. So I end up throwing something and it gets perceived as something a little bit more intentional and a little bit more aggressive. And so that can happen there. Conduct disorder, on the other hand, is different. It's usually behavior that is much more severe than oppositional defiant disorder, and it's intentional. So the difference between ODD and conduct disorder is typically intentionality. Usually with ODD, there's other, like we said, that irritable mood, that impulsivity and poor decision-making is contributing. Whereas with conduct disorder, it's usually way more intentional, and the behavior is very much more motivated to hurt. But you can, again, see aggression as part of that clinical picture. And then intermittent explosive disorder is just another one that's good to be aware of, kind of similar to everything we've been talking about, that they have usually IED does not include irritable moods in between the explosions. But again, you see aggression in those. Trauma can also cause a lot of anger and a lot of aggression, which I think can make sense to a lot of us. Acute stress disorder versus PTSD is just about the time frame mostly for symptoms. So acute stress disorder, you're diagnosing within the first month, because PTSD doesn't get diagnosed until a month after, at least a month after a trauma. And so it just kind of gives us different ways to conceptualize how severe the symptoms are or what's going on. Anger and aggression can be associated with these. For that same reason, we think of with anxiety, that fight or flight, that alarm system gets turned on, and it's usually in relation to trauma symptoms or trauma reminders. Mood changes are also associated with acute stress disorder and PTSD. So again, it's just part of that clinical picture. And then that last bubble is all of our neurodevelopmental issues, disorders. So there's lots of reasons why aggression can pop up there. ADHD, again, we can see that some of that impulsivity and inattention can cause some of those behavioral responses. With ASD and an IDD or an LD, a lot of times that anger and aggression can come from frustration. They're overstimulated, they can't do what they want to do, people are not understanding them, and so they can have some big outbursts because they either can't inhibit their behaviors or they're so overstimulated they kind of reach their breaking point and can respond in that way. Next slide, please.
So there are other causes for anger and aggression, and we're going to talk about state anger. So we're looking at the physical well-being. Are they in pain? Is there an illness? You know, do they have the flu, or are they having the flu, or are they having sinus issues? I know that I'm kind of a bear when I have a sinus infection or if I have a migraine. I don't want people to talk to me. I might snap at people. I don't feel good. I have anger with that. And that's just me trying to deal with the pain because I don't feel good. There's also medications that need to be, it might have a side effect, drugs, alcohol, and then social environments. If the kiddo or adolescent or adult is having a lot of, social environments, like they're having issues with peers, they're maybe not in a safe household, they may lash out because of that. Sleep hygiene. I'm sorry, that slide looks a little wonky. Sleep hygiene is important. I know that sometimes whenever I don't get enough sleep, I'm kind of cranky. Same with kids. You need to have, and this is I love this poster. I had it in my office when I was seeing clients because a lot of people don't realize how much sleep a kiddo actually needs. And then different things that can affect it. Temperature is a huge one. I like it cold. I also like a fan because it makes noise. I have to have it dark when I sleep. I'm so glad that I don't have to do nights anymore because that was a nightmare trying to find blackout curtains that actually work. And then also, you want to limit their food and drink consumption, just a little bit of water. And for some kiddos, that caffeine, even though they have it in the morning, they have, a Coke with their lunch or something like that, that might affect them later on in the evening. So and it also has, I love this picture because it also has imagery because, I'm a visual learner, so that helps me a lot. Diet. Okay, disclaimer, I'm not a nutritionist. I don't pretend to be. These are just some of the things that I've noticed that whenever I'm working with parents with kiddos or adolescents, that when they do these small changes, some of them, it works miracles. The kiddo is a little bit better, and sometimes it doesn't work. But again, you want to try all avenues. So, making sure that the kid eats breakfast is a big one. I know that if I don't eat breakfast, I get a little hangry. I'm human. Same with kids. You want to make sure that maybe they have kind of more of a protein-rich foods instead of sugary foods, because sugar, they might have all of this energy and then they crash. Because again, you want to make sure that it's not raising blood sugar. Then again, the protein breaks down a little bit differently than sugar. Some clients said that they added fish oil and that helped. Again, I'm not a doctor. I'm not claiming to be. Unprocessed food, sometimes parents say, hey, we're trying to kind of switch more toward, the organic or, cutting out processed foods. We've seen that that's helped. And then dyes. Sometimes kiddos have, an allergy to red food coloring or yellow food coloring, and that can affect their behaviors too. Next slide, please. Thank you.
This is just a brief overview of some of the prevalence and maybe, more demographically things to look out for. I think the biggest thing we take away from this is that, especially when it comes to anger and aggression that occurs within a clinical disorder, boys are much more likely, or, traditionally presenting males are much more likely to present with anger and aggression. We see in 3% or 3 to 5% of children with ODD or conduct disorder are likely to present with that more aggressive side. Same thing with our irritability and our mood. You see quite range there. And we see that, some rage can happen in anxiety. And just overall, sometimes we have kiddos, 5 to 26% in just clinical or non-clinical populations can present with some of that anger. So it does happen in our kiddos. It's not always connected to a disorder, but usually it does have a cause. And that's why it's really good to understand the environment, the kiddos, like Elizabeth was talking about, hygiene, sleep hygiene and well-being, and just understanding the context a little bit more. Okay, next slide.
Okay, I love this this graph or this information and how it's presented, because even though it says normal child, which that's the one thing that I don't like about it, because there's no such thing as a normal child. There's not. So I like how it breaks up into, how can you tell the difference between a quote unquote normal child and somebody that has a diagnosis of some sort. So whether it's dyslexia, whether it's a learning disability, ADHD, autism, I like how that breaks up. So it also talks about how to cope with anger. So, how, and we're going to kind of go through a de-escalation activity later on. But I just wanted you to kind of look through this while I'm talking about things to think about when you're with the behavior to avoid it. So you identify it, you help the child to cope with it. Now let's talk about how you avoid it. So you want to try not to escalate the child's anger or emotion by yelling, so raising your voice. You don't want to match their energy. Because if they're coming up and they're bowing up, and you don't want to match that. You also want to watch your words. You want to avoid stimulations that are going to sprout an anger outburst. You want to prevent the children from feeling neglected. And this is more for parents. So you want to, you want them to become more involved in school activities or quality time at home, which that can be difficult to do. Depending on what's going on, and COVID hasn't made it any easier. Humor. Okay, so if you use humor with anger, you want to make sure that it aligns with the situation and how you're communicating. I know that, for example, my husband uses humor. That is his defense mechanism. We had so much issue with that because he would do this nervous laugh, and I thought he was laughing at me, which ticked me off even more. So once I understood that that's his defense mechanism, I know that he's very uncomfortable when he starts just like giggling. So be aware of that. If that's your defense mechanism, that you do that whenever you're in a stressful situation, just be aware of that because of how it may come off. You don't want to create leeways if there are rules that are already set. You want to follow through with appropriate consequences. You want to also avoid punishment or consequences that don't fit the crime. And then there's this form also went into kind of the spanking principle. And again, it kind of depends on the school and it kind of depends on the parent. I personally say you want to avoid it. But again, it's depends on the parent, what the parent wants, because if they sign the form, they sign the form. Next slide, please.
Okay, so we're going to talk over a quick case example to kind of reflect on, what have we learned about causes, and then also to keep in mind as we talk about it. So Jack is a 10-year-old male who just started the 5th grade. He presents to his doctor's office with his mother to establish care as they moved to the area from out of state about 2 months ago. Jack's mother states he's always been an energetic child. However, his new teachers are complaining that he lashes out in class when he's asked to kind of transition between things, when he's asked to complete work independently, or when he needs, is kind of forced to stay in his seat. He's also pretty aggressive with his peers at recess. So if you feel comfortable in the chat, go ahead and throw out some ideas of where are you seeing anger or aggression in Jack? And the other thing I'll ask too is, so if you do, where are you seeing some signs of anger and aggression in Jack? And then what do you think could be some potential causes for Jack's anger? The lashing out in class definitely is a big one. Do we think he's probably maybe a little angry and aggressive at home, and maybe mom just isn't reporting it right now? Maybe, probably. If he's having a hard time with transitions in class, he may also struggle with that at home. Or maybe mom has some really good systems, at home that are keeping him from being aggressive at school or at home. Yeah, maybe nervous, absolutely. Totally a possible learning disability. We're not sure what's going on with his education, so that's a great thing to look at. And yeah, so I like this idea of trying to fit in social issues at school. Yeah, pair him with a buddy, that's great intervention. Awesome. Yeah, thank you all for those ideas. I agree. There could be, I think adjustment is a big thing to consider here. And I like how we're also considering, these other things about nervousness, about possible learning difficulties, because, 5th grade, that's every educational year is a new jump in expectation and developmental stages, or, learning expectancy. So, nice job. Okay. So next slide. So we'll keep Jack in mind as we talk through some interventions. So the first thing, kind of like, this was pointing out with recognizing anger, is the best way for intervention is prevention. The best thing we can do is try to prevent behavior. And so there's things to keep in mind. One big thing is the difference between developmental and chronological age. Chronological age is just exactly like it sounds. It's how old a child is based on their birthday, right? Developmental age is more so where their development, their learning, their cognitive and adaptive and social abilities are. And so if those two things are mismatched, we may have expectations for our kiddos that aren't reasonable based on their developmental age. And that can go both directions. Maybe they're a little bit more advanced developmentally and we need to raise the bar, or maybe they need a little bit help developmentally and we need to adjust the bar accordingly. So good factors to consider are the diagnosis for kiddo, what's going on there, their maturity level. So just naturally, how do they compare to their peers in class as far as when it does come to maturity things. Any trauma history, which can definitely impact their developmental level, depending on when trauma occurred and to what severity. Birth order kind of goes to that maturity. I'm sure, as we've seen, kiddos, when families with kiddos, that the birth order can make a difference in lots of different ways. And as we said, the social environment, again, knowing what's the context they're in, what types of kiddos are they hanging out with, what has their socialization been before entering your doctor's office or before entering the classroom, and keeping those things in mind. Developmental age is going to be the biggest component of intervening effectively, because if we're, like I said, if we're not matching that developmental age, our skills may not hit the mark for that kiddo. So in early childhood, 3 to 5, you're looking at a lot of other regulations. So when we think of anger and aggression, that kiddo is going to really rely on other people to help them regulate. So we're going to talk more about specific skills, but this is going to mean that you need to be prepared to talk kids through their feelings, help them use the coping skills that you want them to use, help them seek out safe environments and make good choices. They're probably not going to do that on their own. So it needs a lot of modeling and a lot of hand-holding, essentially, when they first learning how to do that, so that they can get to a point of co-regulation. And so co-regulation is usually what you're looking at around that middle childhood. And that just means that they can somewhat regulate on their own, but they still need some support. So that's going to be a lot of not necessarily walking a kiddo through how to do deep breathing, but maybe suggest to them that that might be the best thing for them to do. Encourage them to start identifying their own needs when they get to a certain point. And we're going to talk about how you can do that. A big thing in this stage with co-regulation is helping them catch themselves early. And prevention, that's a big thing of what we can do, but also it helps the kiddo do it as well. And then adolescents, they're going to be typically getting a lot better at self-regulation. And so sometimes that just means giving them their space. when they are angry or they are kind of showing some aggression. Obviously, safety is key, but once you know they're safe and they're good, just giving them that space to regulate on their own, and they'll reach out when they need more help. So yeah, next slide. Okay, so like we said, the best intervention is prevention. And so I'm sure a lot of our teachers are going to be very familiar with functional behavioral analysis. We're kind of using the ABCs. But this strategy essentially allows us to understand what happens before, during, and after a behavior, because the more we understand what's happening, the more we can intervene on it. If we understand the who, what, where, when, why of what might trigger anger and aggression, and also when we start to understand what happens after, what response occurs, and how does that help a kiddo get their need met? Because that may be reinforcing things unintentionally. A lot of times I work with families, we look at sometimes some anger and aggression is just because they're needing connection and closeness, and that's the fastest and most effective way to get it. If I start screaming my head off and throwing things, caregiver is going to pay a lot more attention to me than if I'm calm and just kind of saying that I'm sad. So understanding what is the function of the behavior and what are all the factors around it is going to help us address it in the most effective way. Within schools, this is really effectively done with special education. They definitely have behavioralists, available to kind of help walk through this process and to help teachers complete it as well. It's also something you can reach out for outpatient support as well. If your kiddo is involved with a therapist, they can come observe in the school or what have you. Or this is something you can help a teacher understand how to do, a parent understand how to do, or a caregiver. So, if you're in the doctor's office, you can find wonderful handouts that kind of spell out this whole model, like this one right here, and then just blank templates that kind of give them an A, B, and C column. And you can ask a parent or a caregiver, hey, start to track the behaviors. When you notice a tantrum, once it's over, sit down and chart it out. What was the time of day? Where did it happen? Who was involved? What were they doing immediately before? What did the behavior look like? And what happened immediately after? Because the more we can understand the function of anger and aggression, the better we can address it. Elizabeth?
So this was one of the forms that I had in my office. And again, I was whenever we were creating this presentation, we wanted to make sure that PCPs are going to get something out of it, but also educators are going to get something out of it. So I kind of combined a couple of different formats, and this is the one that I like the best. So, and I'm going to kind of go through it with you very, very quickly. So the first step is to kind of look at your body language. So you want to respect a child's and your personal space. You want to keep at least 2 arm lengths distance away. If it's a smaller kid, you might want to get a little bit closer. But again, you want to make sure that you offer room for your own personal safety. And also you want to see as non-confrontational, non-threatening in the eyes of a child. You want to ensure that both you and the child have an unobscured pathway to the exit. And you want to not stand in the way of the child's path of leaving the room. Again, in a classroom setting, might be a little bit different. You don't want to corner them, is what I'm trying to say. You don't want to provoke. So a lot of our interactions are not communicated by the words we say or how we say them. Again, it's our body language. So you want to be mindful and attempt to be very, very calm and patient. You want to keep your hands visible, maybe bend your knees slightly, avoid excess or direct eye contact, and approach the child in an angle instead of head on. This is going to come across as a non-threatening demeanor. You want to establish vocal or verbal contact. So if you're the first person to interact with a child, you're going to be the one who's going to lead the verbal de-escalation. This is more ideal for a clinic setting. You also want to introduce yourself and ask their name. Again, this is more of a clinic setting, if it's not known. You want to be courteous and caring. Use short, simple, very simple vocabulary to get your point across. You want to give the child time to process, because again, they're up here. They're processing reasoning is kind of, it's floating out the window a little bit. So give them time to kind of compute what's going on and what you're saying. And you want to, again, you want to give them time to say something before you continue. And you might have to repeat your message multiple times for the child to understand. You identify their wants and their feelings in order to provide empathic care. You want to understand the child's perspective, or try to understand the child's perspective. You want to listen carefully to what the child is saying and pick up any clues or responses that they may desire. One tactic to use is, I really need to know what you're expecting when you came in to see me today. Even if I can't provide it, I would like to know what we can do to work on it together. That's more of a clinic setting statement than an educator statement. But for an educator, you can just say, hey, I'm trying to understand what you're needing. So can you communicate with me with that? Some kids they're not going to be able to because they don't know how, but you're offering that window for them to communicate what's going on. You want to listen closely to what the child is saying. You want to practice kind of a closed loop communication. You want to repeat what the child has told you to ensure that you understand them correctly. Agreeing or agree to disagree. Look for something that you can agree on with the child. For example, I agree waiting for a toy can be frustrating, classroom setting, versus I understand that the nurse gave you 3 shots today, clinic setting. However, if you can't find something to agree on with the child, do not lie, agree to disagree. You want to also set very clear limits and boundaries. You can preference this with saying, your behavior is making me uncomfortable, and that makes it difficult for us to help you. Again, you hear how my tone of voice also changed. You want to coach the child on how to stay control. You want to give the child tactics to use to de-escalate themselves in the situation. For example, if you sit down, we can discuss what we're going to do. You can also use relaxation techniques if needed, and we'll go over a few of them later on. Next slide, please.
Okay, so this is more referencing when behavior becomes a crisis. So obviously, that prevention key of identification and preparing the setting for the kiddo, and then obviously de-escalation are ideal, but sometimes behavior still gets escalated, things get out of hand, and it does become a crisis where safety is an issue. So these are kind of rules that across settings and may just change a little bit depending on where you're at. But the first thing is that I'm big on prevention. So establish a safety plan and a crisis protocol beforehand. If you're in a medical setting, obviously that is something you want to talk with like your clinic manager or your nurse manager about to figure out, okay, what are our processes if things kind of escalate. And then within the school, this might be something that is part of the kiddo's IEP, or maybe something beneficial to sit down and do with parent and kiddo beforehand. This is something you can also teach caregivers how to do. The more you can involve kiddo beforehand, the better, because then they have more buy-in to the crisis plan, and that hopefully will make compliance a little bit easier. So you want to review that with everyone, either when you make it or maybe kind of regularly before situations occur. Always know your options, particularly when it does come to what is allowed by your institution as far as intervention, and also what other crisis options you have. So always default to what your organization recommends, like within the schools, especially when it comes to containment and intervention. That might change based on if you have like a SAMA training or what you're allowed to do. So just be aware of that and be prepared, especially if you know you have a kiddo who may have some difficulties with these things coming in. Use the crisis services when they're necessary. Call 911, get an ambulance to take kiddo to the ER. I believe it's Andrew Center that has their new crisis line for like autism and things, knowing that you have options. And then if a child is unable to maintain safety and the caregiver is unable to maintain safety, it's okay to intervene, with some more drastic steps. That becomes, if we have to call CPS, if we have to involve organizations like that to help get resources and maintain safety, that's the biggest thing. Because a lot of times that's all it is. It's just helping get the appropriate resources to prevent this type of crisis and escalation from happening again. Okay, next slide.
So interventions. So who's going to be involved? So the family and the kiddo is going to be involved. The teachers are going to be involved. The PCP is going to be involved, and the therapist, which I guess I should clarify, PCP is primary care provider, not the drug. Just saying. Next slide, please. Okay, so this is a slide more for educators. So one of the things to look at is how do you see the behavior manifest in the classroom? One thing to consider is how the child is engaging with other children's teachers and other authority figures. You want to document everything that helps identify behaviors. So this could be setting. So is it happening on the playground? Is it happening more when it's a virtual classroom versus a physical classroom? People involved, time and date, and it's way easier to remember what to document with the WWW and H, which is who, what, where, when, and how method. The reason why I want to talk about this is how it can be helpful. I had a kiddo who came in and I was actually able to provide them with the right type of therapy treatment and treatment plan based off of the teacher's documents and their notes. It was that teacher's notes were vital to creating the right kind of treatment plan for this kiddo. Teachers spend as much time, if not more, with students and their parents, especially, you know, when the kid goes home and they're sleeping and that kind of stuff. Educators may pick up on actions and behaviors that parents are not seeing or don't wish to see. This could also be due to a number of factors such as environment, stress in home, peers. So what happens if the parents aren't involved? And this is a slippery slope. You can call CPS. There's pros and cons to that. You can ask to be a mentor and see if the child is willing to talk or if they want to talk. And I want to kind of talk about the stress of being a teacher, especially about what's happened in the last few months and the last year. So teachers wear so many different hats. They're educators first and foremost, but now they're protectors. Now they're, you know, they're the listeners. And in some case, they're the parent. So for teachers, I know that you've heard about burnout. It's something that, you know, it happens to us all. And I think that, you know, sometimes teachers will just kind of like therapists, they just kind of like shove it down and then they get burned out. Another thing to kind of look at is the reactions to teachers when you ask if they want to talk. Some kids, they're going to open up. Some kids they're going to be polite and say, no, you know, I'm good. Some kids might say, no, F you, I don't want to talk to you. I don't have a problem. So it's good to remember that you've said something, it's embedded in their brain. You planted that seed that you were a safe place to talk about. Very quickly, my mom had a teacher who created a suggestion box, and this is for anything that happened, whether in school or in their life. And everyone had to put something in it, even if it was just their name. And she, now that, you know, my mom and I were talking about this, and she said now that she was an adult, she really, really appreciated that because because of this classroom suggestion box, she's able to actually like talk to professors when she got older. And I'm sure that the teacher found out all kinds of things that the kids maybe weren't comfortable about verbally saying it, but they could write it down. So that's just kind of an idea of what's going on in the classroom that teachers can do. Next slide, please. Okay, so classroom tips for anger management. Acknowledging that anger is perfectly normal and is healthy for children to express appropriately. You want to acknowledge the child's feelings and let them know that they're valid and that you understand. Students should know that being angry is okay, but they have to express their anger in an appropriate way to deal with their feelings. Emphasize that anger can be expressed in a calm and respectful manner. Recognizing the difference between anger and aggression. Although there are two similarities and it may occur together, Anger is the emotion that is the result of frustration, low self-esteem, or disappointment, where aggression is the negative act. And, it's that intention to hurt somebody or something. Negative consequences should focus on aggression and not necessarily anger. You want to try to prevent conditions in the classroom that are likely to induce frustration or anger. For example, be sure that tasks are explained in an appropriate level for the student's ages or ability. You might have to repeat some things. Be proactive, both an anger outburst. You want to talk to your class about acceptable and non-acceptable ways of handling their frustrations and situations. Once a problem surfaces, you want, it may be difficult for the students to consider a better way of handling their feelings. Again, they're ramping up. Okay, encourage anger-prone children to avoid situations that will likely cause their anger and help prepare them for situations that may be unavoidable. For example, you want to advise one student maybe not to play at recess near those who he believes are going to tease him, and have him rehearse what he might do if teasing does occur, both at school and at home. You want to recognize that students are prone to becoming anger, often fails to take precedence over understanding different situations by other students. So you want to try to overestimate the likelihood of positive occurrence. So I bet tomorrow will be a better day. Teaching problem solving skills. So you want to stress the importance of listening in both eyes and ears. So again, you want to think of different ways to solve problems and making them, that may make them angry or compulsive, or to evaluate their own actions. Again, it's that body language that's very, very important. Encourage children to slow down and think before they act. So often a child will get angry and it boils over and they don't think about the consequences, and then something happens and there's a consequence. So teaching children techniques to observe the situation before acting can reduce the behavior from occurring. So again, take 3 breaths before speaking or acting in any way. Count to 10, or if really angry, count to 100. Imagine a peaceful, relaxing place. Tell yourself it's not worth it. Write in a journal, or just a couple of them. You want to encourage the child to express his or her anger verbally. Rather than using physical aggression responses, you can talk out their frustration. For example, I don't want to share right now. I would rather play with my own toys instead of yours. You want to encourage a student to, walk away and cool off. You can help them avoid their anger from overcoming him. With younger students, creating a cool down chair or a spot in the room where they feel comfortable while they calm themselves. For older students, it might be, allowing them to go see a counselor for intervention, or, go get a drink from a water fountain. Be the example, modeling appropriate ways of handling difficult situations and frustrations. So you want to let the student know that adults sometimes have difficult times dealing with their feelings too. Give examples of how you want to cope. So think it aloud when you're angry. Okay, I'm a little upset and I need to calm down a little. When it's appropriate, you can use humor. But again, it goes with that. Is it a defense mechanism? Is it going to do more harm than good? And then compliment the children when they demonstrate problem-solving skills or managing anger management techniques. When the child reacts in a way that is an appropriate manner, tell them it's important to acknowledge the good behavior as well as the bad. And again, what's going to work in your classroom for you and your students. So you can take all of these and use them. You can not take them. But again, what's going to work for your classroom. Next slide, please.
So Joshua, your question's actually perfectly timed because we're gonna kind of move into a little bit about that because I love what you bring up on anger comorbid with ADHD is a big one. We know ADHD is comorbid for several disorders, aggression being and anger being one of them. And that's a good point. You know, medication, depending on the underlying reason for the anger and aggression, medication may or may not help. You know, if it's aggression due to anxiety, ADHD medication can kind of be an additional kind of stressor on that because it's a stimulant and all that good stuff. So those recommendations are really good to have, and I'll point those out as we finish up here. So this slide is just to kind of point out specifically for primary care and medical providers what your role is, because a lot of times, as Elizabeth said, teachers are the ones who are like on the ground floor with the kiddo for most of the week. And so unfortunately, sometimes the burden of responsibility does fall on the teachers in the school to really provide that intervention. And while it's a perfect setting for it, because we know our teachers and administrators are very compassionate and have a drive to do that, it does put a lot of stress. And so sometimes what can be best done by PCPs and other medical providers is to provide resources to caregivers so caregivers can start to do some of that work as well. Unless you are seeing a kiddo multiple times on a pretty regular basis, intervention may not be as easy. So big things are stuff we've talked about. Gain as much information as you can to help inform those recommendations. Helping parents learn how to track those behaviors like we talked about so that they can start to notice, okay, what are the things I want to change? My kiddo doesn't exist in a vacuum. If I believe that my kiddo is angry and aggressive just because that's the way they are, that creates a lot of hopelessness, both for kiddo and for the caregiver. So helping them understand what's going on and what are the warning signs and the triggers can be very helpful. Resources, like I said, are going to be the big thing. There's wonderful handouts on all of the skills we've talked about today, and I'm going to, on the next slide, point out some more specific ones as well. There's always good handouts for that, and that's something you can definitely provide. And also feel free to get them connected with other services in your area, counseling, assessment. Give them the TEA website so they can start to explore special education. You as the medical provider can provide that written proof of a diagnosis so that they can get 504 accommodations. You know, there are so many things that you can do to be an advocate and to provide resources. That's really the big role that primary care gets to serve. And that brief education. Explain why co-regulation is important. Explain why emotional awareness is important. You know, being in events like this or talks like this help you gain some knowledge that then you can impart onto your caregivers. Okay, next slide. So this is an overview of a lot of the stuff that we talked about today, just to give you some more concrete things, and kind of goes back to, like you're saying, that comorbid with ADHD. Developing cues and helping your kiddo understand their cues. This can be really helpful for our ADHD and our impulsive kids. And we know anger can be connected with that impulsivity. Instead of having to think of the words to express how they're feeling, all they have to do is give you a cue. Raise their hand, hold up a peace sign, whatever it needs to be. It can kind of be that cue so that they don't have to do the extra cognitive process of, I have to think about the words and I have to get their attention and do all those things. Creating emotion identification tools, which I'll show you on the next slide, can look like a lot of different things, is a really, really great way to do this. Modeling and practicing positive behaviors are awesome and really important. Our kids are mirrors of us. They do exactly what we do. So the more we can model and not be afraid to say, I'm feeling angry right now. I need to do something to calm down. Do you have any ideas, kiddo, about what I should do? That gives them some autonomy. It helps them practice what they're already trying to practice and is a great way to do it. Same thing, practice emotional labeling. Even if kid is using angry words and angry body expression, it can be really hard not to want to correct that in the moment. But a lot of times, if our kids are angry and aggressive, they're at 100, they're not in a space for correction, they're in a space for learning. So being able to model that. And then creating behavior charts. So behavior charts often list out a target behavior, not that the kid doesn't throw, but that maybe kiddo keeps hands to themselves. That would be a target behavior, and then they can get reinforcement for that. And then with our older kiddos, behavior contracts can sometimes work. So maybe our teens, we can create a behavior contract that says, I agree to abide by these behaviors. I agree that I get these privileges or this reinforcement when I do these behaviors. Sometimes that can help. And on that right-hand column is just some clinical approaches to therapy that you can look for if you are providing referrals to parents. Okay, next slide. So these are some visual examples of some of that emotion identification and emotional awareness. Creating a feelings thermometer that helps kiddo label what does this emotion look like and what can I do in response is very helpful. And this also gives a tangible way for kiddo to recognize when I'm at my breaking point. And then that emotional checking in can be really good too. So it doesn't necessarily have to be like a thermometer. It can also just be acknowledging what emotion I'm having. Okay, next slide. I know we're at time, but I think, Elizabeth, you can kind of review this one and other recommendations and we'll be good.
So here are just a couple of ones that I found are great. One of them is when I'm angry, and you have different things that they can do and it's written out in front of them in black and white, and maybe they come up with their own too. Grounding practices, you can, I love grounding. You can do it in different ways that meets the needs of the person who's doing it, whether it's a child or whether it's an adult. And then breathing, you just need to take a deep breath. I really like this box breathing because you can also get the kid to kind of run their fingers on the arrow. So it's also that stimulation of touch. And PCPs and adults can use those. Some of the other resources I have, if we can throw the PowerPoint back up, and I have a couple of other resources to consider, which are just mental health apps that you can use. And I also put the pricing on them too.
Hey, Elizabeth, because it's the top of the hour, we're going to have to show the QR code because some of the providers are going to have to leave to get back to clinic.
Gotcha.
But if folks are interested in the PowerPoint slide, we can send that for sure.
And I included my email in the chat as well, so feel free to reach out with any questions or if you're looking for resources. I know Elizabeth and I are both very open and available to help connect you with those.
And I'll be adding the QR code here in just a second for the teachers and the counselors and such who have joined us from the T-Chat as well. So I would be excited to see if there are any additional questions that we could talk about. This is such an important topic and so much information. Dr. Schneider, I don't know if there's any additional questions in there. I'm going to let you look at the chat.
I don't see any right now, but yeah, if you do have any additional questions, feel free to throw them into the chat. And I know Elizabeth and I both kind of struggled with how much to include because there is so much good information, especially for the varied populations that we had here today. But hopefully this gave y'all a good overview of things to look out for, ways to be preventative, and ways to intervene. And if you ever, as I said, want any additional information about how to apply it to your specific setting, good resources or referrals in the area, please feel free to reach out.
All right, so this is the QR code for the teachers. And then Jen, I think you were also going to put that in the chat. Wonderful. I have 2 screens, but I really need 3 today. I'm not able to see everything. I'm going to go back to the one for the providers real quick.
Yes, for T-Chat participants, in the chat, there is a QR code as well as a link to be able to access that. And that will be active for probably about a week. And after that, it will be a different QR code that can be viewed through the YouTube channel.
All right, so right now we're showing the QR code for the CPAN attendees. Our primary care providers, counselors may have joined us on the CPAN side. And I'm going to show the other one again here real quick. All right. See the slide for our T-Chat folks. You know, there's so many questions as you were going through the information, Dr. Snyder and Elizabeth, so many questions that came to my mind. I think about there's, you know, for some of the behaviors, there's really no magic pill. It's really a matter of learning skills, it sounds like, for the children that struggle with the ability to control their anger and their outbursts and their aggression. At least it seems that way to me. What are your thoughts about that, Dr. Schneider?
I would agree. You know, there are certainly our pharmacology has come a long way, and depending on the etiology of the anger, there definitely are medications that can be really helpful. I think that kind of brings us back to, and I feel like it's my soapbox because I'm all about prevention and identification, but that's really what is going to help guide your intervention, is starting to understand what is the rhyme and reason behind this anger and aggression, because that definitely changes how we address it. Because if it, you know, especially on the medication side, aggression as the result of anxiety versus aggression as the result of ADHD are two very different things. And we want to address those differently. And sometimes behavioral intervention is the key. Or sometimes, you know, as we know, a lot of our research says that combined treatment is the way to go. And that's especially true for our kiddos. We know that for a lot of our kiddos, as they're maturing and their developmental age is increasing, that behavioral intervention alongside any sort of medication-assisted treatment is going to be ideal.
Great, thank you. Elizabeth, you know, when you've worked with children in your history as a therapist, and you see them in areas, because you said your history is that trauma and domestic violence and crisis and such, you know, what's maybe one thing, if you only have a short period of time with a child, what's maybe one thing that you do to try to help them as a therapist?
So building their resource, their toolbox is very, very important. Even if I have just a couple of sessions with a kiddo, I want to strengthen those different resources that they have so that they're comfortable with it and they can use it. They can call upon it when they're in a fight, flight, or freeze place. So again, that deep breathing, sometimes we forget to breathe, even though it's an automatic response. We'll hold our breath, we'll get tense. Sometimes just letting that go and allowing our body and our brains to kind of come back down to our normal, quote unquote, level helps a lot. And then also, you know, telling them, are you in control or are your emotions in control? I love the movie Inside Out because that kind of explains emotion and who's driving the bus. Asking that with kiddos, adults, and adolescents really does help. So you know, just making sure that their toolbox is filled and they're comfortable using those tools.
All right, thank you. Elizabeth, Dr. Schneider, we really appreciate your time today. Jennifer, is there anything else that you want to add?
No, ma'am. I think you ladies did a wonderful job. And again, yes, I want to thank both of you again for all of this wonderful information. You know, this is definitely something that is applicable to a large population, but specifically TCHAP participants. So thank you very much.
Yes, thank you. And thank you for joining us, everybody. Have yourself a great rest of your week.